The Positive Pause is a motivational-minded podcast covering topics women want to know about as they journey to and through menopause, focusing on subjects that impact women's health and healthy aging, including what it means to age healthfully. The Positive Pause features experts and influencers from a variety of industries and specialties. The information and opinions expressed on the Positive Pause are not intended to replace the services of trained professionals or to provide specific medical advice. To see the National Menopause Foundation's full medical disclaimer, please visit nationalmenopausefoundation.org.
Welcome to the Positive Pause. I'm Claire Gill, founder of the National Menopause Foundation. Joining me today are Dr. Emily Lau, a cardiologist at Massachusetts General Hospital, and Michelle Routhenstein, our cardiology dietitian. Dr. Lau is a women's cardiovascular health specialist and investigator. At Massachusetts General, she directs the Cardiometabolic Hormones and Health Clinic, and her lab works there for a focus on understanding how biologic sex differences and female-specific cardiovascular risk factors contribute to the pathogenesis of cardiovascular disease uniquely in women. Michelle is the owner and president of Entirely Nourished, a specialized private practice in nutrition counseling and consulting focused on the prevention and management of heart disease. She utilizes a science-based, holistic approach to enhance women's heart health by addressing cardiometabolic risk factors and mitigating the likelihood of cardiovascular issues as we age. She is deeply committed to educating individuals on nurturing their hearts for healthy and thriving lives. Thank you both for speaking with me today.
Thank you for having me.
Thanks for having us.
Delighted to have you guys here to talk about this incredibly important topic. And let's start off by talking a little bit about why, we approach midlife and beyond, heart health becomes more important. So Dr. Lau, why don't you start off with that?
Absolutely. Well, first off, thank you again for having us on this podcast, really shining a light on such an important issue. Many of us don't realize that midlife is a very important time in a woman's cardiovascular health. And that's because before the midlife, women's risk of heart disease actually lags significantly behind that of men. But we see following midlife and the menopause transition that cardiovascular risk actually accelerates in women and even catches up to men. And so this really highlights the midlife is a very important time for cardiovascular risk prevention and optimization. And I'll also highlight that while many people think that heart disease is a man's disease, it's very much a woman's disease. Heart disease accounts for between 1 to 2 or 1 in 3 deaths in women worldwide. So this is a huge and important issue for women.
It's fascinating to me that, again, we've made some strides in talking about heart health. Heart attacks are the number one killer of women. I think that's still the true statistics, right? That is how morbidity happens most in women. But I don't know if that message of midlife becomes a critical point has really gotten through to the consumer population anyway. Would you both say that's true? Are you seeing advances where women are becoming more aware of the increased risk at midlife? Or do we still have a lot of work to do?
Yeah. I mean, I think the issue is that heart disease happens silently. So it's not like you feel plaque brewing in your arteries. You don't feel high blood pressure. You don't feel high blood sugar levels. And so a lot of times, if it's not on someone's radar, they're not thinking of the importance of it until, unfortunately, an event happens or a more severe diagnosis occurs. And so we end up being more reactive versus preventative because we're not brought up to the fact of understanding how it's progressive. It takes many years and decades, depending on your genetics, to show up at a later stage of heart disease. And so we need to bring more awareness and we need to recognize that we can control it. So it is the number one killer globally over all cancers combined, yet 80 to 90% is preventable. And so I always say, let's take that empowered knowledge of knowing we need to be testing our labs. We need to be looking further into this and recognizing the importance of optimizing them to prevent heart disease and its complications.
So, Dr. Lau, and same topic on that, on whether or not there's any kind of awareness building that's been improving. Do women know when they come to you or in your pets that they have a family history of it? I mean, because family history plays an important role, but as you said, Michelle, so much we can do to prevent it. But are we at least making the connection that if someone in our family has it, we need to be more aware?
Yeah, I think the issue of awareness is a really important one. The American Heart Association had conducted a study that asked women to assess what they thought was the leading cause of death among women. And they first conducted the study in 2009. And at that time, about 2/3 of women were able to correctly identify heart disease as the leading killer of women worldwide. And then 10 years later, they conducted the same survey again. And you would have hoped that awareness would have increased, but actually we saw the opposite. We saw that awareness had significantly declined in the 10 years that had passed, and that less than 50% of women could correctly identify heart disease as the number one cause of death. So I think those data really highlight that we have an awareness issue, that we really need to be doing a better job at helping our communities, our patients, the public recognize how important cardiovascular disease is in women. And I think it's just as Michelle said, so much of cardiovascular risk is silent until, of course, heaven forbid, you have a cardiovascular event. And so the concept of prevention is a tricky one to be able to translate to patients because you can't see it, you can't feel it. I will say when I see patients, most people have an understanding that their family history or the disease that runs in their family does influence their own health overall. But I think what we're not seeing necessarily is the connection between our risk factors, the time of life, and what we need to be doing to really optimize and prevent cardiovascular disease from developing. There's definitely still an awareness gap there.
That's really important. And it's funny, as you guys referenced, like the silent disease of cardiovascular issues. We have the same, obviously, on bone. And I think I've shared many times on this podcast about my other hat as the CEO of the Bone Health and Osteoporosis Foundation. And it's funny because when I talk to people about osteoporosis, obviously the same thing. You don't feel your bones getting weak. But when I said to my mom, who was a retired nurse, that you have osteoporosis, you broke your hip, that she had actually told me that I was in the business of telling people they have osteoporosis. And I said, well, your cardiologist told you have cardiovascular disease. She's in the business of telling people they have cardiovascular disease. But her response was, but I can feel my AFib. Right. And I was like, oh, interesting. But as you said, if you don't have that, then you're in the exact same boat where, wait, there's nothing wrong with me. And trying to convince patients that they really need to do a lot of that preventative care and screening and paying attention and awareness, whether you feel it or not, is so, so important. So that also leads me then to, Michelle, another point that I often talk about with experts on this podcast, in that when women are approaching midlife and when they're approaching menopause, and the focus tends to be around, a little bit of weight gain, right? And that's where women start to pay attention and notice. And I just was having this conversation about someone last night who's writing about GLP-1s and saying that oftentimes what people don't recognize is we have this, societal thing that thin means healthy, but that's not necessarily true at all, right? Like that you could be thin or maintaining the same weight, but that doesn't necessarily mean that your cardiovascular health is good. Your blood pressure could be bad. Your cholesterol could be bad. So what should women do as they approach midlife to evaluate how they're doing as far as preventative action steps, or even what should they be looking for in their diet or their blood work to determine, I need to pay more attention to this?
So like you said, heart disease can happen in any body size, in any body shape, and honestly, in any fitness level. We see plaque formation happen in athletes. So we need to make sure that we're checking blood work, because a lot of things can happen beneath the surface, and we need to be looking at those levels. But I'm going to put a caveat here too. I think a lot of times we look at these ranges and people are not getting that personalized attention of what are your targets. If someone has a high Lp(a), their targets for ApoB cholesterol is much lower than someone who doesn't have a high Lp(a) or doesn't have a family history of heart disease. So we need to be personalizing those targets, but we also, especially in women, need to be looking at inflammatory markers. Are we checking hsCRP? Are we also checking at LPIR, lipoprotein insulin resistance, and blood sugar levels and blood pressure? I think when people think of cardiometabolic health or cardiac health, they only think about LDL cholesterol. And while LDL cholesterol is important, anything that's excess in the blood vessel can potentially cause more plaque to form, could put more pressure on the heart to do its job, can increase the risk of heart failure, atherosclerosis, heart attacks, and strokes. And so we have to be more proactive. As women go through midlife, their nitric oxide bioavailability goes down. Their blood pressure can go up. And many times it's like people will say, oh, it's just white coat syndrome. It's just anxiety. Get a blood pressure cuff. Check that at home. Make sure that we are knowing your numbers, but also knowing what are your targets and improving them and monitoring them closely so that we can get ahead of it and help to prevent any potential issues.
And that can be done, like I said, even when people think that they've been doing things right and they're not necessarily thinking about all of those other things, like you said, that impact what happens to our heart health. And Dr. Lau, in your lab, you focus on then the connection between hormonal health and cardiovascular health. And I hear so often that there's still so many things we don't know about that connection. So can you talk a little bit about what do we know? And then what are the gaps that you and your colleagues are still trying to understand through your research?
No, thank you for that question, because that's exactly it. I think one of the challenges for all of us who are in this space, really treating women, midlife women, whether that's preventing heart disease or the women who have heart disease, is that the available evidence base is very limited and it's really complicated, actually. So we know a number of things, and a lot of the data that we know comes from the study of women's health across the nation, or the SWAN study, which is a prospective study of the menopause transition. We know that there's substantial increases in a number of lipid and lipoprotein molecules that have been shown to elevate one's cardiovascular risk, like LDL cholesterol, total cholesterol, apolipoprotein B. And we know that during the menopause transition, the increases in these lipid measures actually seem to accelerate, that the changes that we see seem to be beyond what we would expect just due to chronologic aging alone. We also know that there's a shift in body composition. So the available data now actually demonstrate that the midlife or menopause is in general weight neutral. But what we're seeing is that the type of overall body composition shifts quite a bit. So during the menopause transition, we see that visceral adipose tissue increases quite a bit while lean mass declines. And this is really important because visceral adipose tissue, which is the fat that surrounds our internal organs, is highly inflammatory and has been shown to be associated with greater risks of heart disease later in life. Now, there are other things that are a little bit more mixed, like what happens with blood pressure. The data there are a bit more mixed, and it's possible that some women have different types of trajectories across the menopause transition. But so there's a lot of epidemiologic work that has demonstrated that many of the cardiometabolic measures that we look at when we're trying to make sure that a woman remains healthy or heart healthy, that there's a lot of evidence that demonstrates that these measures actually increase during the menopause transition. I think the big area of research that still remains unanswered is the why. Well, what is happening during menopause that leads to these adverse changes in cardiometabolic health? And why does a woman's risk of cardiovascular disease really accelerate during this important life transition? I think the easy hypothesis that many of us for many, many years sort of assumed that we thought this was all an estrogen issue, right? Because menopause, what happens during menopause? Well, our ovaries stop producing estrogen, but it turns out the answer is much more complicated. And so I think really trying to peel away and get at the mechanisms, the why we're seeing these changes, why women are at greater risk for heart disease after this life transition is an area of interest of our own research lab and many investigators here in the US and worldwide. But it's really complicated. Our hormonal system and our reproductive system and that intersection is very sophisticated. There's a lot of networks. There's a lot of complex interplay.
And isn't it? I'm never endingly fascinated by how incredible, complicated, unique the female body is and our hormonal makeup is. And it's a challenge, like we said, when it comes to studying it, but it really is truly amazing. But is that part of it too? I've also heard that the reason there's not a greater focus on figuring this out is because of those complexities in a woman's, in the hormonal issues, that it's more expensive to study, right? And I understand that, but as a consumer, I'm like, there's no excuse, right? We still have to figure this out. And so we really do need to champion research in these areas to get at these unanswered questions. Because like you said, I would assume too that it's all hormonal. And the thought that, wow, there's more to it than that is really interesting. And not knowing what all of that is and the whys is frustrating, where it's 2025 and we haven't figured out how menopause actually impacts women. That's crazy to me.
Yeah, no, you're absolutely right. I think it is harder. It's very much harder. And I mean, even when you talk to basic scientists who do animal studies, it's much easier to study male animals compared to female animals. And then this is true every step of the way, from preclinical studies to clinical studies to large randomized trials. It's a lot simpler to study male or men subjects. And it's much more expensive, I think, as you point out, and it's much more complicated, which really highlights how important it is for us to have the opportunity and to have funding mechanisms to be able to do this important work in women's health in general. And that's been an area that is sorely needed and has been underfunded for so long. I think that fortunately in 2025, we're starting to see many more foundations recognize the importance of women's health and really prioritize that. But it barely scrapes the surface of it.
Right. Just a drop in the bucket. And I appreciate again that those family foundations and foundations, like you said, are stepping up, particularly as government funding has gone away in many instances. I just want to stay on the research for one more second, because the other important thing I think we need to make sure we communicate when we talk about women's health research is that women need to be willing to participate in that health research as well. And so I just want to put in a plug for, as we're looking to develop more resources to study women, then we also need to ensure that women are available to participate in those studies. And those are challenges that are unique to women too, right? Primarily with childcare and all of those things. So not only is studying us complicated, but the role that women play in society and stepping away to participate in these studies or to add on participating in these studies is also a complicated factor. So we really need to think through that and advocate as patients and as all of our clinical partners, how do we make sure that we're doing both of those things? So turning then again to, okay, we know we still have gaps to study, but there are several things we really know. And as you said, Dr. Lau, we know how fat changes that fat changes happen in the body, not exactly how, but that it's going to happen, and that changes it. So that leads me back to, again, both of you then, what should women be doing, perhaps differently, even if they don't, but what should they be thinking about as changing nutritionally? Are there things, Michelle, that we should think about? Cut back on this, like maybe cut back on this, or add more anti-inflammatory? What are some of those easy things that women can be doing just to start taking steps to improve their heart health, even if they don't know that they have heart issues?
Yeah. So one of the things you did mention is that you don't feel heart disease, but maybe during menopause, you feel that distribution change, that abdominal weight. Maybe that you feel like you gain a couple of pounds and you want to make sure that you lose the weight. That may be on someone's mind. And so I'm going to come in and say something that maybe not so traditional. I find a lot of women will go on a very low calorie diet because they want to lose weight. And during menopause, you need a lot more nutrients in your body, and we need to be looking at what you're adding in versus what you're taking out. A lot of times we focus in, oh, I don't eat this, I don't eat that, I'm going low calorie. But when you only focus on calories, you actually don't look at nutrient density and getting in the vitamins and minerals that your heart, your vascular system, your body needs to thrive and do its function. So in order for you to kind of assess that, a first tip in my book would be, what are you not eating? Right? How many people are not eating enough fish and enough omega-3 fatty acids, which help reduce inflammation and stabilize plaque and increase HDL functionality? Let's start there. And if you're someone who says, I'm allergic to fish, I don't like fish, okay, but we can then have a discussion of what that may look like for you. A lot of people now always define their diet. I don't eat gluten, I don't eat dairy, I don't eat this, I don't eat that. Well, okay, what are the nutrients found in those foods? And let's make sure you're getting them to support your bones, to support your heart, to support your brain, to support your kidneys, because a nutrient adequate diet is going to support blood flow to all of your organs. And if you put it in the right pairings, you can help also optimize your labs too. So my biggest tip is kind of making sure you're eating enough and eating to your metabolic rate to help with weight loss, but also to ensure you're protecting all of your organs in your body in the interim.
So how important is like that tracking what we're eating? Because I think if you ask the average woman at midlife who's running around, whether kids are still in school or they're gone to college and they're taking care of parents and doing stuff, what was that trend that we were talking about, like the stand up, like snack eating, like women were just eating crackers and stuff at the table? What should we be doing? Should we track our diet for a week and then be able to bring that either, like I said, to whatever clinician you're with, but certainly if you're having heart issues, I would imagine, Dr. Lau, even for you, knowing what the diet is that they're consuming helps you determine what to do with them as well. And certainly, Michelle, as you're trying to figure that out, you can do tests to figure out what they're missing. But what do you start with? Is that like track your meals for a little bit to give me a better sense of what you're consuming?
Right. So you could do it that way. A lot of times, though, when you do that, if you're putting it into an actual like MyFitness or Chronometer, it can become more of a math calculation, and we're not trying to calculate everything to that component. I would much rather kind of go meal by meal. Okay, are you eating breakfast? Are you eating within 30 to 60 minutes of waking up? When you eat that meal, are you satiated? Does it take you 3-4 hours to be hungry again? If the answer is no, I'm hungry an hour later, then you're missing either protein, fiber, healthy fat, carbs in that meal. And so when you do it that way, it's not as overwhelming. We're not here trying to overhaul someone's diet that doesn't last long term. We're trying to create a long-term lifestyle plan that will help someone optimize their cardiometabolic health in their labs, give them the nutrients they need, allow for functional aging without it being a math equation, but rather, oh, I feel good. I have energy this way. Oh, wow. My waist circumference has come down. My labs are improved. I'm seeing what I'm doing works. And that takes small changes. That does not take an overhaul. Overhaul and diets don't last. We see that in the research. It's about personalizing it to you and making sure it fits in your body. So I like to go meal by meal. It helps reduce the overwhelm, and it also helps to kind of stay focused. Okay, one tip this week, I'm going to work on breakfast. The second thing may be, well, let me see my activity level. Am I exercising? Do I have aerobic in my week? How much? Do I have resistance exercise in my week? How much? What is one thing we can do in physical activity, right? And then maybe another one is on stress management or sleep hygiene, because those will also influence nutrition. And when you just do a couple things at a time, then you're like, oh, wow, I feel better and I only did this. Okay, I'm ready to do another thing. And it becomes long-term habits. Small changes add up quickly. Big changes don't last long because they're unrealistic long-term.
Yeah. And Dr. Lau, what do you see besides the nutrition factor? What are things that women should be paying attention to or addressing to improve their heart health?
When I meet with patients specifically to talk about prevention, we really think about a number of important metrics. And we really focus on the modifiable things. So we think about blood pressure, making sure that we are being aggressive at ensuring that our women's patients are getting to their target blood pressure. I find that time and time again, we are much less aggressive with women patients in terms of trying to get them to their heart measured targets. We look at cholesterol in particular. We spend a lot of time on LDL cholesterol because we know that is causally linked to greater risk of cardiovascular disease. But Michelle mentioned a few other lipid measures that we also pay attention to: HDL cholesterol, lipoprotein A, ApoB. We spend a lot of time talking about diet and exercise, but I also agree that draconian efforts, like really extreme behavioral changes, are not very sustainable. Like, I think the best thing that we can offer our patients are ways to really integrate heart healthy behaviors and lifestyle changes into their lives so that it becomes part of their day to day rather than something that they have to do. Or I think that when you really try to adopt something that is very extreme, whether that's an extreme diet or an extreme exercise regimen, I think that it's very hard to sustain those over time. And then we do talk about weight. Of course, we talked earlier about how there are many individuals with heart disease at all spectrums of weight, but we do know that elevated weight, certainly overweight or obesity, are important risk factors for cardiovascular disease. And then we also talk about sleep. I think a lot of people don't think about the relationship between sleep and cardiovascular health. And so that's an important factor that we discuss in clinic. And finally, mental health. Depression and anxiety are associated with greater risk of heart disease. And I don't think we're doing a great job sort of addressing our patients' mental health. So we really try to talk through all of these different elements and really think about ways that we can optimize one's overall cardiovascular health, but in a way that is really about really thinking about adopting a heart healthy lifestyle. It's not a crash diet or like suddenly I'm going to be doing a very extreme exercise regimen. How can we really integrate this into one's day-to-day life so that these really become a part of a way of life rather than almost like a punishment?
Can you talk a little bit to Dr. Lau about what we know and don't know? Because I get this question all the time about hormone therapy and both preventative or risk of cardiovascular issues.
Yes, I think the $1 million question, and there's a lot of controversy in this field. And this is very timely because just on Monday, the FDA removed the box warnings on all menopausal hormone therapy estrogen products. And I would say that the history of hormone therapy with respect to cardiovascular disease is pretty complicated. I think for a long time, we all assumed that if we gave women hormones, that would prevent cardiovascular disease. And that seemed to make sense, right? We just talked about how heart disease risk really accelerates after the menopause transition. We know, what happens during menopause? Well, the ovaries stop working. They don't produce estrogen anymore. So it made a lot of sense. If you give back estrogen, which was what we all thought and assumed to be cardioprotective, then we were absolutely going to be preventing cardiovascular disease. And there were some really robust observational studies in the late 90s that supported this. There were data from the Nurses' Health Study, which is one of the leading observational studies in women's health, that demonstrated that there was a very strong association with exogenous hormone therapy use and reduced rates of cardiovascular disease. But in the late 90s and then in the early 2000s, two landmark randomized trials came out that really changed the way that we think about hormone therapy, especially with respect to cardiovascular disease and also breast cancer risk. And those were the HERS trial and the Women's Health Initiative trials. HERS was published in the late 90s, and this was a study that looked at women who had a prior heart attack. So women who had existing heart disease, and these women were randomized to either receive hormone therapy or placebo. And to the surprise of everyone at the time, hormone therapy did not reduce cardiovascular events. And if you actually really look closely at the data, in the first year after these patients were randomized to receive treatment or placebo, there's actually a greater risk of cardiovascular events in the hormone therapy arm compared with placebo. But the real landmark study that I think has truly transformed the face of women's health was the Women's Health Initiative. And this was a study that looked at hormone therapy for women without a history of cardiovascular disease. So we were really trying to answer the question, does menopausal hormone therapy prevent cardiovascular disease? And in the Women's Health Initiative, we found that treatment with exogenous estrogen, both with or without progestin for women with and without a hysterectomy, did not reduce cardiovascular events. And in fact, there was a signal for greater thrombotic events, so like blood clots and greater risk of stroke in the hormone therapy arm. And I would say that those results were so seminal and they really changed the way that hormone therapy was prescribed in this country. So before these two trials were published, over 90 million prescriptions of hormone therapy were being given out every year. And basically every woman, their grandmother, mother, everybody was on hormone therapy. And after the Women's Health Initiative, the WHI trial, hormone therapy prescriptions essentially plummeted. And now, even in 2025, only about 3 to 4% of women really get hormone therapy per year. And that probably translates to about, 10 to 15,000 prescriptions, so much less. So in the interim, there have been some other analyses. So they actually went back to the Women's Health Initiative trial. They looked at their data with a different lens. They had longer duration of follow-up. They stratified by age. And it actually turns out that there's a lot of nuance to these findings, and that when you start hormone therapy may actually influence your cardiovascular risk. And specifically, it seemed like if you started hormone therapy at a younger, like if the initiation of hormone therapy was in younger women who are less than 60 years of age or less than 10 years post-menopause, they did not see the same evidence of harm and maybe even some potential benefit. Whereas it looked like the increased risk of cardiovascular events was really in that older, further out from menopause group. So that sort of led to this concept called the timing hypothesis, which basically said that if we give hormone therapy to women at a younger age, less than 60 years of age, less than 10 years post-menopause, that we think that it's safe. And there were a few other follow-on randomized trials that have supported this concept. So where does that really leave us now? It's pretty confusing. I think the pendulum has shifted so many times and continues to shift. I think that hormone therapy, what we know today, based on the available evidence, is that hormone therapy, if initiated in younger women, so less than 60 years of age, less than 10 years post-menopause, in women who have low, at most intermediate risk of cardiovascular disease, hormone therapy is thought to be safe. But hormone therapy should not be used for the prevention of cardiovascular disease. Hormone therapy can be used for hot flashes, menopause-related symptoms, prevention of bone loss, vaginal atrophy, and hypoestrogenism, or from premature hypoestrogenism. Those are the 4 FDA-approved indications. You'll notice that prevention of cardiovascular disease is not an indication for hormone therapy. So that's, I think, a really important point. And so there's a lot of nuance. There's a lot of controversy in the field. There's a lot of discussion. I think there'll be even more discussion after the removal of the boxed warnings. But what I would say is that it's really important for patients to have a very detailed conversation, an individualized conversation with their providers as they're thinking about hormone therapy, to really go through the risks and benefits.
Yeah. Thanks so much for explaining that, because that's the kind of, we get back and forth on is there a benefit, but also there's not that huge risk that we originally thought from the Women's Health Initiative. And I really think that's so important as we talk to women about what the science says, is that science is living and evolving, right? And as you said, the Women's Health Initiative was incredibly important and continues to be incredibly important. And so it really upsets me when people say it was wrong. It wasn't wrong in the population it was looking at. We just know now more from evaluating the longer term study than we did then. And so I really love how you describe that nuance of, this is what we were working with. This is what it is. And here's where we are today. And so it's important that women know that. And I agree. I've been at that FDA meeting. I think getting the black box warning off all estrogen products when, specifically there were ones that should never have had the warning to begin with, right? It was wrong then. Swinging the pendulum all the way back to now where we're moving it off everything isn't doing a great service to women either. And it's really incumbent upon all of us in both the clinical community, the patient advocacy community, to encourage women to have that conversation with your doctor, right? It's safe for 80%, but you want to make sure, again, your specific health risks are addressed so you can make an informed decision about, look, my quality of life is so miserable right now. I'm really with hot flashes and such, you said, I'm really worth the risk for me of that. I have no family history of it. I don't have to worry about heart disease. I may not worry that much about it. Those are conversations that we need to empower women to have and be sure to do that. And so I know we're quickly running out of time and I could talk for hours with both of you, obviously, but I also just want to ask Michelle, is there a difference in nutritional deficiencies for women that might be on hormone therapy or not? Like, does that play any influence in what changes as we reach this stage of life? Like, so again, if we're starting to see deficiencies because we have hormonal deficiencies, and if someone's on hormone menopause therapy, they may not have these deficiencies, or is it strictly just nutrition and hormones separate?
I mean, so we don't have the studies saying that hormonal therapy will prevent deficiencies. It's just as we age, our body requires more of certain nutrients because a certain absorption goes down. If we have more bone loss, we need to make sure we're having enough calcium, vitamin D, K2, magnesium. We need to make sure we're getting in those because as we age, our nutrient volume needs to increase both from a bioavailability standpoint and a utilization standpoint. So that's really what we're shifting from a nutrition perspective as women age and go through menopause and beyond.
So regardless of hormone therapy, no hormone therapy, the nutritional aspect is incredibly important and is going to change. And women need to be able to access resources and people like you and information about what they can do to restore that balance, right? Because that's what we're really trying for.
Yeah. And, I think it's also important to say when we're collaborating from a cardiologist to a dietitian, we are not separate people. We are integrated. Medication can coexist with nutrition. Nutrition can coexist with medication. One does not overtake the other, even if it's a genetic metabolism disorder like FH. What you eat will matter even more in every situation, but that does not take away sometimes the need for medication. And I say that because I think a lot of people look like, oh, well, I'm on medication. I can eat whatever I want. Or, oh, I'm not on medication. I'm going to just focus on my diet. And we need to have a better collaboration between the cardiologist and the dietitian. We are on the same team to help our patients reduce the risk of cardiovascular events and live a long, healthy, and awesome life.
That's so important. And I love that point too, because I say the same thing. And I know from the bone side, right? The medications actually are more effective if you are following the right nutritional guidelines, right? And so letting people know, like you said, it's not an either or. It is they work in conjunction. It's all together to kind of bring about the best possible results. And I love that. Okay. So I really do need to wrap up for this one. So if there's one thought that you'd like to leave our listeners with about improving or maintaining or anything around cardiovascular health at midlife and beyond, I know it's limiting to one is hard, but what would that message be? Dr. Lau, I'll start with you.
I would say that the midlife is a real opportunity, an opportunity for us to think very intentionally about how we can optimize cardiovascular health. Prevention is absolutely key, and this is the time to do it. We already discussed how cardiometabolic health really changes during the menopause transition. And so if we can be very intentional and very aggressive about ensuring that our patients are entering and exiting the menopause transition with the most optimal cardiovascular health. And I think we can really make a difference for the lives of women.
Wonderful. And Michelle?
Mine is very similar in that take an empowered approach. I think a lot of times we focus in on the negative of, oh, this is what's going on. These are inevitable. You can control more than you think, but that requires you to be your own advocate, to ask questions, to get support if needed, and make sure that you are taking that empowered approach of what can I do instead of, oh, it's inevitable. Turn the fear into empowerment. Your mindset is a huge control on kind of how you take this and how you help with improving your future self and health.
Thank you so much. That is both great advice and so important. And we need to hear that message over and over again, really, especially for women when we don't prioritize our own health. So again, I'm so delighted to have had the opportunity to talk with you, Dr. Lau and Michelle Routhenstein, for sharing your time and experience with us. We'll include additional information and resources about your work and about some of the topics that we talked about on this episode with the episode notes. I hope you've enjoyed this episode and learned something. I know I have. And if so, please subscribe to the Positive Pause podcast so you never miss an episode, and share this important information with your family and friends. Thank you again to my guests, Dr. Emily Lau, cardiologist at Massachusetts General Hospital, and Michelle Routhenstein, cardiology dietitian. And thank you for listening. We hope you'll tune in to another episode of The Positive Pause.